Let's start with the lecture of severe sepsis and septic shock. And the first thing which we will discuss is the anatomic essentials of sepsis and septic shock. The microbes or the causative agents responsible for causing infection or sepsis, they need to break down the barrier, which is the barrier created by the epithelium or epithelial lining. So after the microbes attack the epithelial barrier, you can see these are the microbes and they break that epithelial barrier and then they enter inside after breaking the epithelial barrier. And then the infection reaches inside. Now what happens, we have the immune system, and the immune system, function of the immune system is to protect against infection by destroying the microbes or the causative agent. So if the person's immune system is strong enough, they will fight that microbes, fight that infection, and the outcome is not as severe as the person who have weak immune system. So once the infection reaches the inside, then we have the macrophages. Macrophages are the type of cells that fight the infection. And then we have also the neutrophils. So these are the neutrophils. These are the macrophages, and you can see they entrap the microbes, they take the microbes inside and phagocytize them and destroy them. So these are the phagocytic cells which have neutrophils, macrophages. They take the microbes and destroy them. Once there is efficient pathogen elimination, if the, as I mentioned, immune system is strong enough, they will take in the microbe and destroy and kill them. And then there is usually resolution of local inflammation or infection. The other scenario is if there is inefficient pathogen elimination by the macrophages and the neutrophil, then they reach the blood vessel and they cause infection or sepsis in the which can be very, very severe. As we move on, and we will discuss different complications and features of the sepsis, you will see sometimes sepsis can lead to severe complications, and it is associated with high mortality rate if it's not properly managed. So sepsis is basically once the microorganism, pathogenic microorganism capable of causing disease, they break the barrier, epithelial barrier, and they enter the body. There we have the immune system, which includes the cells like macrophages and neutrophils, which are white blood cells. White blood cells are the cells responsible for fighting infection. So they fight against those microbial organisms, those microbes, and if the attack is strong enough, then usually there is a resolution of local inflammation. But if the attack is not strong enough, the microbes reach the bloodstream and then cause sepsis. So that's the whole description of the sepsis, and then sepsis can lead to septic shock. So microbes breaking the epithelial lining, entering the blood vessel if the immune system is not strong enough. Then systemic inflammation can lead to sepsis. So once the infection reaches the blood vessel, through that blood, it reaches to the different organs of the body, different parts of the body, and cause systemic sepsis. Systemic sepsis means it spreads throughout the body, and as I mentioned, it's a serious condition. Usually it's hard to manage the patient if the treatment or management is delayed, can cause complications and have high mortality rate. Next, now again some anatomic essentials. We have, this is the organism, microbes, then systemic inflammation or inflammatory response. So as I mentioned, if the management or if the prevention of the attack by the microbes is not strong enough, it can cause systemic sepsis or systemic inflammation. Now, from that systemic inflammation, what happens? This cause diffuse endothelial disruption and microcirculation defects. So as a result of sepsis, now the endothelial lining of microcirculation, which is capillaries and small blood vessels, it's the endothelial lining of those blood vessels or capillaries is destroyed. Next, after the destruction of the small blood vessels, capillaries, damage of the endothelium lining, we know that the gas exchange takes place in the alveoli at the level by the capillaries, and if the endothelium is destroyed at the level of microcirculation, at the level of capillaries, then the supply of oxygen to the different parts of the body, to the different organs of the body is affected, and this can cause hypoxia of different organs of the body. Then if it's severe hypoxia, it can cause multiple organ dysfunction and refractory hypotension. So it causes dysfunction of multiple organs, including lungs, kidneys, heart. So all the organs of the body start affected by the hypoxia and poor circulation and by the infection and sepsis. And this ultimately can cause shock. So now we know the relationship between the sepsis and shock. Shock is the very low blood pressure, hypotension. Patient can lose the consciousness, they become unconscious, there is very low blood pressure, and the relationship between the sepsis and the shock. Now, if I summarize it, the microbes, they attack the epithelial barrier, enters the body, where the white blood cells, macrophages and neutrophils try to fight that infection. If the fight is strong enough, there is no, it's just a local infection and it's diffused. But if it's weak, then it can cause a severe infection and it can spread to the blood vessel, where it can cause damage to the endothelium, to the microcirculation, and it can cause global hypoxia. Global hypoxia, tissue hypoxia, because the blood supply to different organs of the body is not good enough. And then if it's severe hypoxia, it can cause severe multiple tissue or organ dysfunction, and there is hypotension, refractory hypotension, and this hypotension can cause shock. So very, very comprehensive, summarized description of the sepsis and the shock. Next, we will discuss over the normal mechanism of the transport of the oxygen. If we see here, this is the heart. That's the right atrium, right ventricle, left atrium, left ventricle. The blood becomes oxygenated once it enters the lung and it gets the oxygen. So the superior vena cava, roughly if I describe the circulation or the blood flow through the heart, we have a superior vena cava that brings the blood from the upper part of the body, and inferior vena cava that brings the blood back from the lower part of the body into the right atrium. From the right atrium, blood goes to the right ventricle. Now this is the blood which is deoxygenated or has no oxygen. It's coming back to the heart, and then from the right ventricle it goes to the lungs and get the oxygen. And the vessel that carries the blood to the lungs to get oxygen is the pulmonary artery. So remember, at this point, pulmonary artery is carrying the deoxygenated blood. So the other very important thing we should know is the pulmonary artery is the artery. Arteries carry oxygenated blood, but pulmonary artery is the artery that carries deoxygenated blood. It carries the blood to the lungs, get the oxygen, and then come back. Oxygenated blood comes back to the left side of the heart through the pulmonary vein, and then from the left it goes to the left ventricle and then to the aorta, and from the aorta blood is distributed to different parts of the body, and then again the blood comes back to the heart. So this is very brief description of how the blood flows through the heart. So central venous oxygen content, central venous oxygen, head and upper extremity. If, as I mentioned, superior vena cava is bringing the blood from the upper part of the body, and that gives us the oxygen level in that is give us the central venous oxygen content. Then we have the arterial oxygen content, saturated arterial oxygen content is there in the aorta. This is the aorta. So it's the arterial oxygen saturation is by the aorta. Again, this is the venous oxygen content because this is the blood that's going, if you see, to the lungs, and the lungs gives the oxygen. So this is against the venous oxygen content. And this is the oxygen that combines with each molecule of hemoglobin, attaches the oxygen, and this oxygen is delivered to the different parts of the body as the blood flows to different part of the body. So each molecule of hemoglobin attaches 4 molecules of oxygen. So this is the oxygen attached to the hemoglobin. So we have superior vena cava bringing the blood from the upper part of the body, and this gives us the saturated venous oxygen, central venous oxygen concentration. Then in the aorta we have arterial oxygen saturation, and then we have again this is the pulmonary artery. Again, it's the artery, but it carries deoxygenated blood and gives us the venous saturation. This is the hemoglobin, as I mentioned, and each hemoglobin carries 4 molecules of oxygen. and the oxygen is delivered. As the blood flows, it comes from the aorta and then different branches distributed to different parts of the body, carries the oxygen and deliver it to the lower part, different parts of the body. Remember, where the oxygen concentration is low. So where the oxygen concentration is low, it is delivered to those parts of the body. And depending on, again, as the tissue demands, so which tissue needs more oxygen, it's delivered according to that demand. And then oxygen is extracted and again deoxygenated blood. So this is superior vena cava, bringing the blood from the upper part of the body into the right atrium, and then this is the inferior vena cava. Once the blood is distributed, oxygen is delivered, the blood comes back to the heart through inferior vena cava, again from the lower part of the body. So this is the circulation. Next, we will go over this graph again. It's just giving us the example, as I mentioned, that depending on the tissue demand, if the oxygen level or oxygen is low in certain areas and that portion needs more oxygen is delivered to that particular tissue. So depending on the tissue demand, the delivery of oxygen depends on that. So we have lactate, venous oxygen saturation. If it increases, if the level of lactate is increasing, venous oxygen concentration is increasing in this direction, then the delivery of oxygen is usually maximum oxygen this is the critical oxygen delivery threshold. So if you see, as the lactic acidosis, as a result of all these changes, as a result of sepsis, we have lactic acid builds in the body, and this is metabolic acidosis. And once there is increased level, there is decrease here. When the graph shows the venous oxygen concentration, that's the point where the delivery of oxygen is maximum, and that's the point where the oxygen should be delivered at the maximum level. So that's the threshold here. Next, we will discuss about the cardiovascular insufficiency and global tissue hypoxia. So infectious insult after the infection. So again, like a summarization, how this infection caused the sepsis and what is the effect of that sepsis on the function of the heart and on the how it can cause global tissue hypoxia. So after the infection, inflammatory mediators, I mentioned we have macrophages, we have neutrophils that try to fight that infection by ingesting the microorganisms. And this can cause hypovolemia, decrease volume, vasodilatation. So inflammatory mediators can cause hypovolemia, dilatation of the blood vessels, myocardial depression, the heart muscles, the ability of the heart muscles to contract is depressed. And there is cytopathic tissue hypoxia and microcirculatory impairment. So as I mentioned, there is destruction of endothelial lining, and that endothelial lining causes hypoxia and impairment of microcirculation, and with the impairment of microcirculation, there is decreased supply of oxygen and it can cause global hypoxia. So these are some changes that occur as a result of infection and inflammatory mediators. This can all cause cardiovascular insufficiency, global tissue hypoxia, and there is markers of high risk patient. Organ dysfunction. So again, the same summarization is with the infection, there is inflammatory mediators activation that cause hypovolemia. Blood volume is decreased, and with the blood volume also there is dilatation of blood vessels that further decrease the volume, hypovolemia, hypotension, and this causes depression of the myocardial activity, and there is global hypoxia leading to multiple organ dysfunction. The inflammatory mediators can be, can be coagulation and neuroendocrine mediators. Next, the risk factors for the severe infection. Severe infection, what are the risk factors? Dementia, delirium, aspiration. People usually who are dementia, forgetful, they are delirious, they are not conscious, they are more patient who have more chances of aspiration. All these are the patients who can have severe infections. Poor nutrition. If the nutrition is poor, the patient or the person will have poor immune response to the infection, and that is more likely to cause severe infection, and severe infection leading to sepsis. Decreased gag and cough reflex. If there is decreased gag and cough reflex, then there is no person cannot get rid of the microorganism that reach the body or the throat or the respiratory system, that can be again lead to severe infection. Endocrine deficiency. Endocrine deficiency can cause severe infection. Immunosenescence T and B cells. So again, once the effectiveness of T and B cells, which are very, very effective cells for the immune system, which play the role in the immune system, usually their function is decreased with the age, and with the age their function is decreased, then there is again more chance to develop severe infection. Immobility. Immobility is very, very common factor. Patients who are immobile, usually they have more chance of getting infection, getting different skin lesions, breaking of the skin. There is entry of the microorganisms. Access of the microorganism is easy. And breakdown of the skin. Skin is the first protective layer that fight infection or protects the invasion of microorganism. If the skin is broken, then there is more chance that person might have severe infection. Next, again, the risk factors which cause severe sepsis and mortality. Severe sepsis has high mortality rate, so the risk factors which leads to severe infection, I already mentioned in the previous slide. Severe infection can cause sepsis, so it should be very, very closely monitored what are the risk factors patient might have that can cause infection and then severe sepsis. Any concomitant medical diseases, if they are present, usually there might be a chance of severe sepsis. Like diabetes patient who have diabetes, the infections are very hard to treat in diabetic patients, and there is more likelihood that minor infection can become really serious and they can have a high mortality rate. Any condition like diminished cardiopulmonary reserve, age-related decrease in organ function. Some organs are affected with age. So if that is the case, then there is chances of severe sepsis and mortality. Intact or enhanced innate immune responses and cytokine synthesis. So this is intact or enhanced innate immune responses and cytokine synthesis. So these are the risk factors associated with severe sepsis and mortality. Now let's discuss about the physical examination of the patient with the sepsis and severe infection. We have temperature. Usually patient who have infection, they have fever, maybe hypo or hyperthermia. So it can be low blood pressure or high blood pressure. So patients usually who go into shock with hypovolemia, they have cold body, cold extremities, so they might have hypothermia or hyperthermia. Next, in examination, the heart rate. Heart rate, usually these patients have elevated heart rate. They have tachycardia. Because of the decreased supply of oxygen, hypoxia, the decreased blood flow, the heart try to compensate that abnormality, and that compensation is done by the increase in the heart rate or tachycardia. Then we have pulse pressure. Pulse pressure is increased at the start. Pulse pressure is the pressure between the difference between the systolic and diastolic blood pressure. The normal average blood pressure is 120/80. So the normal pulse pressure is the difference between the two is 40 millimeter of mercury. So the pulse pressure is increased. So the systolic blood pressure maybe when the patient is in sepsis and shock, the systolic blood pressure can be maybe 100 and the diastolic maybe 60. So there is a pulse pressure that is increased, which is about the 60. So that's how it affects. Next, there is diastolic blood pressure may rise early in shock, and the systolic blood pressure increases when contractility increases. So these are the some findings in the patients with the severe shock infection or sepsis. Then also some other findings, the mean arterial pressure. What's the mean arterial pressure? That is measured by the diastolic blood pressure plus systolic blood pressure minus diastolic blood pressure divided by 3. So mean arterial pressure, we take the diastolic blood pressure. Suppose it's 60. We take systolic blood pressure, which might be 100. minus diastolic blood pressure, which we said is 60. So 100 minus 60 is 40. And then we divide the 40 by 3, and that gives us the mean arterial pressure. Shock index related to left ventricular stroke work. How effective is the pumping of the left ventricle? That gives the shock index. Skin color. Skin color is very, very important. Pallor, because of the poor supply of oxygen, poor delivery of blood, there might be pallor of the skin, there is bluish discoloration of the skin, there might be swelling or edema. And then we have metabolic, respiratory alkalosis, acidosis can also occur. Again, we have reduced glomerulofiltration rate, paradoxical polyuria. So as a result, because we mention all these changes, hypoxia can affect multiple organs of the body, leading to multiple organ dysfunction. Now, when the kidneys are affected, there is decreased glomerulofiltration rate, and there is paradoxical polyuria. And when it affects the brain, there is delirium and brain failure. Patient is delirious because of poor supply of oxygen, blood, and there is brain failure also. Then we have tachypnea. Tachypnea is fast breathing, bronchospasm, narrowing of the bronchial or bronchioles, and then we have hypocapnia, decreased carbon dioxide level. Pancreatitis, mesenteric ischemia, and ileus can also occur. Then we have neck vein distension, tachycardia, and arrhythmia. So you can see multiple organ dysfunction. It's affecting lot of organs of the body. It is affecting lungs, brain, kidneys, heart, and pancreas, and all the cause ileus. It affects the ileum, and it causes mesenteric ischemia. So different organs of the body affected, and it can cause septic shock and increase the mortality rate. Clinical sepsis. Clinical sepsis is, we have sepsis. Sepsis is, as I mentioned before, that when the infection reaches the blood vessel and it reaches the bloodstream, and here you can see in the vessel we have microorganisms present, and this is causing the sepsis. Sepsis-induced hypotension occurs. Severe sepsis can also occur as a result. Here again, if the fight to microorganism or there is no effective treatment, immediate treatment, then it can cause severe sepsis. Septic shock can occur, or SIRS shock can occur. And it can cause multiple organ dysfunction can occur. So once it reaches the bloodstream, cause the sepsis, cause the hypotension. Hypotension can cause shock, and it can affect multiple organs of the body. Now, some diagnostic testing done for the sepsis and shock, septic shock. The general variables are hyperglycemia, increased blood glucose level, altered mental status. We mentioned that there is brain failure and there is delirium. Fever and hypothermia. Tachypnea, there is fast breathing is present. Again, to overcome that deficiency of oxygen or hypoxia, tachycardia, to overcome that decreased pumping or decreased blood supply. So both factors can occur as a compensatory mechanism. Then there is significant edema, swelling is present. And then there is heart rate more than 90 per minute, so there is tachycardia. The heart rate is normal range for heart rate is 60 to 90 per minute. So above 90 is tachycardia, below 60 is bradycardia. So heart rate is more than 90 per minute. Next, some inflammatory and hematologic variables in the diagnostic testing. There is leukocytosis, increased in the white blood cell count. Here you can see leukocytosis. White blood cell count is more than 12,000 micron per liter, and this is again, the white blood cells are responsible for fighting the infection. When there is severe infection present, naturally there is increase in the number of white blood cells to fight that infection. Leukopenia. One, we have leukocytosis, and then on the other extreme we have leukopenia also, decreased white blood cell, which is less than 4,000. Normal white blood cell count is another scenario. More than 10% is immature form in normal white blood cell count. Plasma, we have a C-reactive protein are present. More than 2 standard deviation above normal value. So we have C-reactive protein in the plasma. And then we have plasma procalcitonin, and again this is more than 2 standard deviation above the normal value. So these are some inflammatory and hematologic variables which are in the diagnostic testing of the sepsis. Some other variables, we have Dole's body, toxic granulation, thrombocytopenia, decreased level of the platelets and protein C is present. D-dimer fibrinogen and C-reactive protein, D-dimer platelet prothrombin time and partial thromboplastin time. And we have fibrin degradation product and interleukin 6. So these are all the variables which are important, hematologic variables, inflammatory variables in the sepsis. Next, some organ dysfunction variables. What they can be, we have arterial hypoxemia. Arterial oxygen is less than 300. So the oxygen saturation in the artery is low. So there is arterial hypoxemia. acute oliguria. Because of, we mentioned, there is decreased glomerular filtration rate, there is acute oliguria can occur, no urine output, and there might be ileus. As a result of inflammation, there is ileus, there is no movement of intestine leading to abdominal swelling and all those different paralytic ileus. Coagulation abnormalities can occur also in organ, which is an organ dysfunction variable. Thrombocytopenia, decreased platelet level. Creatinine increases because of the poor functioning of the kidneys. Creatinine level is increased more than 0.5 milligram per deciliter. And there is hyperbilirubinemia. So increased bilirubin level is also present. Then some other variables which we can discuss in the diagnostic testing. We have hemodynamic variables. And these hemodynamic variables are hypotension. We mentioned there is hypotension, decreased blood pressure, hypovolemia, and this is one of the hemodynamic variable. Mixed venous oxygen saturation and cardiac index is more than 3.5 liter per minute per square meter. So these are some hemodynamic variables. Then tissue perfusion variables, how good or bad, or how bad is the supply of blood to the tissues or supply delivery of oxygen to the tissues. Hyperlactatemia. There is increased lactate level, metabolic acidosis occur if the perfusion is not good. Mottling, elevated anion gap. And there is low bicarbonate level. So these are some other variables. We have hemodynamic variables, tissue perfusion variables also. Mortality. Now, what's the mortality in MED score? So, in emergency department, sepsis, what's the mortality in emergency department sepsis score? Variables are platelet count, less than 150,000 per cubic millimeter. So if there is platelet counts, we saw that there is thrombocytopenia, which is decreased level of the platelets. So if it's less than 150,000, that's not good. Now the odds ratio and the confidence interference or confidence interval ratio of 95%. We will discuss the comparison between the two when we talk about the mortality in MED score. So odd ratio for the platelet count is 2.5, and then the confidence interval, 95% confidence interval is 1.5 to 4.3. Next is the terminal illness in the score. Terminal illness odd ratio is 6.1, and the 95% confidence interval is 3.6 to 10.2. So quite a high ratio in this. Then we have a tachypnea, fast breathing or hypoxia. The odd ratio is 2.7, and the 95% CI is 1.6 to 4.3. Next, the septic shock. How much is the ratio of the septic shock Odd ratio is 2.7 and 95% CI is 1.2 to 5.7. So all these are the scores of mortality in med score. Then we have some variables, bands 5%. Odd ratio is 2.5 and 95% CI is 1.5 to 3.5. Age more than 65 years, 2.2 is the odd ratio and 1.3 to 3.6. With the increase in the age more than 65, usually the organs are more on the declining side, so there is more increase in the mortality rate. Low respiratory infection, odd ratio 1.9 and the 95% CI is 1.2 to 3. Nursing home resident 1.9 and 1.2 to 3. And altered mental status, we have 1.6 to 1 to 2.5. So this is just the comparison between the odd ratio and the 95% clear indication, or that this person might have these problems and it can increase the mortality rate. Next, early hemodynamic optimization. We already know hemodynamically patient is very unstable with the sepsis and then the septic shock. So we should have very early, we should manage that hemodynamic complications and what can occur. Fluid resuscitation, very important because of hypovolemia. Then we should have vasoactive agents are very helpful. Blood transfusions, inotrope therapy, and intubation, sedation, and paralysis. Therapies of the patient or emergency department management of an adult patient. So now we will discuss the management of adult patient and the pediatric age group. So first the adult patient, and make sure the first 6 hours very critical, very important. So how we manage the patient in the first 6 hours. We should perform the blood cultures, very important. So we should know the exact causative organism. So the treatment should be specific against that causative organism. So we should have more better prognosis. So cultures, and remember the blood cultures take about 48 to 72 hours. So result takes time to come. And if the condition is critical, we should start the management, and then once the culture comes, we should always switch the medicine. Timely and appropriate therapy, source control is important, hemodynamic assessment and risk stratification, early goal-directed therapy, and corticosteroids. Low tidal volume, mechanical ventilation, and remember these are the therapies in the subsequent 24 hours. First 6 hours, we said the resuscitation is important, inotropic drugs, and then we should give blood transfusion to the patients. All that is very important in the first 6 hours. In the subsequent 24 hours, low tidal volume, mechanical ventilation, glucose control, recombinant human protein C tricogen alpha, and then empiric antimicrobial recommendations, what antimicrobial drugs can be used. If the source of infection is unknown source, we don't know where the infection comes from, and then we should, or unknown source or community acquired pneumonia, we should give the drug like vancomycin. Vancomycin 1 gram intravenously every 12 hours. So if the cause of the infection is not known, or it is caused by community acquired pneumonia, then we should start with vancomycin 1 gram intravenously every 12 hours. Other option is levofloxacin, 750 milligram intravenously every 24 hours. And then we can also give gentamicin, 7 milligram per kilogram. So depending on the body weight, 7 milligram per kilogram intravenously every, again, 24 hours. Then again, some antibiotic. We know that first we talked about the source unknown and community acquired pneumonia infection. Now, if we know the sepsis source, if it is from the urinary tract infection or pelvic infections, we should treat it by piperacillin and tazobactam and gentamicin. So these are the drugs of choice if the source is urinary tract infection or pelvic infection. If it is from skin and soft tissues, then we should give vancomycin, piperacillin, tazobactam, and clindamycin. And then if it's from the meninges as a result of meningitis, then the treatment is again vancomycin, ceftriaxone after dexamethasone. So these are different drugs options we can use depending on what is the source of the sepsis. Next, stages of sepsis and stages of the therapies. In stage 1 of the sepsis, there is variable MAP. Then we have low venous oxygen circulation, central venous oxygen, and cardiac index. High lactate and vascular resistant, low central venous pressure, and the treatment is, again, we should do the volume. In stage 2, we have compensated and vasodilatory. Stage 3, myocardial suppression. Stage 4, there is impairment of oxygen utilization. And again, that's the stage where there is multiple organ dysfunction is occurring because of poor utilization of the oxygen. In this, we have arterial central venous oxygen saturation is low and high. MAP is low, and then we have mean arterial pressure. Anyway, MAP is mean arterial pressure. And central venous oxygen saturation in stage 2, its mean arterial pressure is low and oxygen saturation venous is high. In stage 3, it's variable and low. In stage 4, its mean arterial pressure is low and central venous oxygen is high. Next, the central venous pressure and lactate, normal, variable, high in stage 3, normal, high in stage 4. Then cardiac index and SVR, high in and low in stage 2, normal or low or both in stage 3, and both variable in stage 4. Treatment is in stage 2, we give vasopressors and corticosteroids. In stage 3, inotropic therapy, and in stage 4, vasodilators and RAPC. Volume therapy. Now, the volume therapy is norepinephrine and epinephrine, dopamine, phenylephrine and vasopressin, and dobutamine. So all these are the different drugs that can affect the volume by changing the blood vessel sizes and by increasing the contractility. So epinephrine, norepinephrine, dopamine, phenylephrine and vasopressin and dobutamine, and nitroglycerin. Changes in the oxygen content. Central venous oxygen is usually normal is 70 to 75% of the normal. So we will talk about what brings the decrease and what brings the increase in the oxygen content. Decreased oxygen content and increased content. We have changes like stress, pain, shivering, hyperthermia, work of breathing. So especially the increased work of breathing, they cause decrease in the oxygen, central venous oxygen saturation. Then we have delivered oxygen level is amount of hemoglobin, how much is the cardiac output, and the arterial oxygen saturation. On these factors depends the level of delivered oxygen, whether it's decreased or increased. Now, increased delivered oxygen again depends on the arterial oxygen concentration, hemoglobin level, and the cardiac output. And it also depends on the hypothermia, anesthesia, decreased work of breathing. So one is increased work of breathing causes decrease, and decreased work of breathing causes increase of the central venous oxygen saturation. Next, some intensive therapy, how we should manage the sepsis intensively, intensive insulin therapy, suspected infection, and document source within 2 hours. So intensive therapy is required within the first 2 hours. We should know that this is the infection, and we have the document source of infection within the 2 hours. High risk patients are the patient with blood pressure 90 millimeter mercury after 20 to 40 ml per kg volume challenge or lactic acid 4 millimole per liter. So if we already give the patient the volume and still the blood pressure is not changing or getting better, and the blood pressure is 90 after 20 to 40 ml of fluid challenge, then we should give the intensive therapy. Antibiotics within 1 hour and source control. CVP, central pressure, if it's more than 8 to 12 millimeter of the mercury. Mean arterial pressure more than 65 to 90 millimeter of mercury. Central venous oxygen saturation, if it's more than 70%, and we should have the goals achieved. So all these are the intensive therapy. We should achieve these goals with the intensive therapy with the antibiotics within 1 hour and source control. For central venous pressure, we should give the crystalloid if it's less than 8 millimeter mercury. So crystalloids are used for the pressure which is less than 8 millimeter of the mercury, and with the crystalloid therapy, if it is more than 8 to 12, it means the goal of the therapy is achieved. Mean arterial pressure, if it's less than 65 or more than 90, we should give vasoactive agents. The goal should be between 65 to 90, so that means the goal is achieved. Central venous oxygen, if it's less than 70%, we should give packed red blood cells or to increase the hematocrit 30% to 30%, more than 30%. If it becomes more than 70%, then the goal is achieved. And for this, we also use inotropes. If the goals do not achieved with all these medicines, there is decreased oxygen consumption, then we should give antibiotics again within 1 hour and source control. So it's a cycle. If the goal is not achieved, we should continue the treatment. Next, we have, if pressure dependent, evaluate for adrenal corticosteroid replacement. Evaluate for R activated protein C for Apache 2 in appropriate patient. Protective lung strategies for acute lung injury and tight glycemic control. So other intense therapy management should be, we have tight control on the blood glucose level, for which we need the intensive insulin therapy. We should protect the lung if there is injury to the lungs, and evaluate for R activated protein C for Apache patients who with the this is the technique or used for the patient who are in the to find out what's the seriousness of the illness, and then if pressure dependent, we should evaluate for our adrenal corticosteroid replacement. Special patients is we have pediatric group for special patients, how we should manage according to the time. We recognize decreased mental status and perfusion. Begin high flow oxygen, establish intravenous, intraosseous access. Very important if we know that the patient is altered mental status and there is likelihood that the patient have sepsis or infection. The first thing we should do, give the oxygen, start oxygenation, begin oxygen flow, and then with the shock, usually very hard to find the vein. So we should access the vein and put the IV cannulas or intraosseous cannulas for the access for the resuscitation of the patient. Initial resuscitation, we should, if second peripheral intravenous, start inotrope. So we start the inotrope, and then if the shock is not reversed, we should, it's a fluid refractory shock. Dopamine and epinephrine is used. Again, if the shock is not reversed, catecholamine resistant shock is present, then we monitor the venous pressure and attain normal mean arterial pressure, venous pressure for age, and then oxygen saturation should be more than 70%. So again, depending on, first with the fluid resuscitation, if the shock is not reversed, we should give dopamine and epinephrine. Still not effective, then we should give the monitor the mean arterial pressure and try to get the normal pressure according to the age of the patient. Normal mean arterial pressure, venous pressure in term newborn is 55. 1 month to 1 year is 60. 1 year to teen is 65. Diagnosis of pediatric sepsis, patient history suggestive of new infection. If it's present, look for 3 signs of infection, and these signs of infection are hypothermia or hyperthermia, bradycardia or tachycardia, decreased mental status, and decreased urine output, warm or cold shock. So we already discussed all these features in detail before also. So same, we should look for the 3 signs of the infection. Pediatric shock, blood and urine cultures should be done, lactate levels, begin the therapy, and then obtain lab studies and document in history whatever the findings are. So if we talk about the disposition, we have 2 choices in that, depending on the lactate level. If the patient has a lactate level more than 4 or equal to 4 millimole per liter, then we should, this is the patient which have a higher risk for mortality. The prognosis is poor for this patient with the lactate level more than 4 millimole per liter, and then these are the candidates for the goal-directed therapy. We should start the goal-directed therapy for these patients. Then the other is patients who do not respond to fluid challenge. So first was the lactate level more than 4 millimole per liter, and then the fluid challenge with patients who do not respond to fluid challenge of 20 to 40 milliliter per kilogram. Then these are again high risk for mortality, and they are considered for admission in intensive care unit. So these are 2 cases which are, one is the lactate level and then who are not responding to the fluid challenge. So with the disposition, our lecture of sepsis and septic shock comes to an end, and in this we talked in detail all about how the infection starts, and if it is not managed initially properly by the protective immune system of the person, then how bad the complications can be. And once the infection reaches the bloodstream, through the bloodstream, it reaches different parts of the body, and due to the changes in the endothelium and in the microcirculation at the capillary levels due to poor supply of oxygen, then ultimately it can cause multiple organ dysfunction, and then multiple organ failure starts, and this is associated with high mortality rate. So that concludes our topic. Thank you for watching sqadia.com.